Dr. Atassi?
Here.
Amy Barney?
Here.
Hal Christensen?
Here.
Marcia Cox?
Here.
Julie Sassoon?
Here.
We stand for pledge of allegiance and a moment of silence. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Good afternoon, everyone.
Good afternoon.
Good afternoon. Call to the public. Call to the public. Form BEDHE is required to address the board during call to the public. Form must be turned in to the secretary before the meeting starts. At this time, the chairperson will call for comments from members of the public on items not on the agenda because of the restrictions imposed by ARS 38.431.01, discussion and action items and action on items brought before the board during this time will be limited to directing staff to study the matter or rescheduling the matter for further consideration and decision at a later date. The trustees reserve the right, as authorized by open meeting laws, to limit the length of comments and to also limit the number of speakers if the speakers are merely going to repeat the comments already made by multiple other members of the public. Tonight there will be a 2-minute time limit per speaker. So did we have any calls to the public submitted?
I did not receive any.
Did not receive any. So moving forward then, we'll go to item number 3.
I make a motion, we approve the 3.1 as presented, the minutes.
A second?
I'll second. Dr. Atassi?
Yeah.
Amy Barney?
Yes.
Hal Christensen?
Yes.
Marcia Cox?
Yes.
Julie Sassoon?
Yes.
New business? We'll have a motion to item 4.1. Do you have a motion to approve the December financials?
So moved. Second.
Dr. Atassi?
Yep.
Amy Barney?
Yes.
Hal Christensen?
Yes.
Marcia Cox?
Yes.
Julie Sassoon?
Yes.
See, didn't it start? Moving along. Item 4.2, discussion and possible action regarding NAEBT. I'd like to make a motion to open for discussion. Possible action regarding NAEBT.
Second.
Dr. Atassi?
Yes.
Amy Barney?
Yes.
Hal Christensen?
Yes.
Marcia Cox?
Yes.
Julie Sassoon?
Yes.
So with us opening this up for possible discussion, we went through an awful lot of information yesterday, and Jamie did a great job of presenting that. And I don't know if anybody thought of any questions after we went through that. I think we have a lot of people in the room that didn't have a chance to hear some of that information, so we can go through some additional information. The opportunity has come before us we've been given an offer from the Northwestern Arizona Employee Benefit Trust, which currently is made up of the City of Lake Havasu, City of Bullhead, City of Kingman. And correct me please to join their trust. They have a self-insured trust like we do, like the district does. With that, their current membership, belly buttons, however you want to put that, I think is around 2,600, I think. And so with our just under 900, or yeah, it's like we have about 890, I think. We would be increasing their numbers by an additional third or so. So obviously, with most plans, volume or increase in numbers and lives is a benefit to the trusts, especially self-insured plans, because with more numbers comes, risk gets spread out. And so the opportunity has been laid before us to join that group. The information will be made available and posted on the website as far as the benefits. They have very, very similar benefits to ours. They actually, I don't know that I saw any vendors that were different. Maybe the life insurance was, but
Life and vision.
vision, okay, oh, the vision was because it was VSP, yeah. But for the most part, the consulting company would be the same as ECA. All of the vendors, for the most part, were the same. The co-pays were less than where we currently are. No, excuse me, the deductibles were different. The co-pays were a little different. There are a few things. Jamie, do you want to kind of review that real quick? And
Which, I'm happy to review whatever, which part?
this, just the overview on the differences between the deductibles and the co-pays out of pockets, the things that were a little bit,
Yep, absolutely. You want me to do it here?
please.
I probably need my glasses for this one.
Sheet ready one.
So I just have the medical and prescription information in front of me right now. And NAEBT offers two plans similar to what the school district is offering now. They offer an exclusive provider plan, which just means that you have to obtain routine care within the state of Arizona using Blue Cross Blue Shield providers. Alternatively, if you have an emergency, you could go outside of Arizona just as you would today. And then there's also a high deductible health plan. So in terms of the benefits themselves, we'll focus on the EPO plan first. Their individual deductible is $600, and the family is $1,800, and that's compared to your current deductible, which is $750 for an individual and $1,500 for a family. So slightly higher on the family side, but lower on the individual side. NAEBT's maximum out of pocket is a little bit higher, $7,900 for an individual, $15,800 for a family, as compared to $4,000, $8,000 currently for the school district. However, the school district does have a separate prescription max out of pocket of $3,900 for an individual, $7,800 for a family. That would go away. That's all combined in the medical under NAEBT. Their office visit copay for a primary care doc at PCP is $5 more than what you have today. It's $25 today under the district's plan. It would be $30 under the NAEBT. Specialist is the same at $50. Preventive care is obviously the same as required by law. There's no cost to you for any preventive care that's covered by healthcare reform. The difference here is that in addition to what is required to be provided under healthcare reform, NAEBT also provides every covered person under the plan $750 additional that they can use for services that aren't covered by healthcare reform. So a great example of that in Arizona is skin cancer screenings. Not required by healthcare reform, something that's critically important. So you could use those dollars for those types of things. When we get into lab and x-ray, again, very similar, the exception being it's an office visit copay if you get lab work or x-ray done in your doctor's office, whereas today that's a $50 copay. And then if you're doing it at a freestanding facility, not hospital owned, for lab work, there's no copay at all. Again, you're paying $50 for that today. Scripts, we have differences in the preferred brand, which would be tier 2, less expensive under NAEBT at $30 for a prescription. They, for their tier 3, which is their non-preferred brands, there isn't more there. So currently you're paying $65. That is actually 75% of the cost on that one with no maximum. And on specialty drugs right now, under your plan, you're paying 20% up to a maximum of $300. Under the NAEBT plan, it's 20% up to a max of $150. So a significant difference there. And then when you talk about your retail or mail, which is your 90-day supply of those maintenance medications, the only difference there is it's less expensive for a preferred brand drug at $60 for that 90-day supply. And then, again, for the non-preferred brands, you're paying a $130 copay today. Under that NAEBT plan, it would be 75% of the cost. And the reason for that is that on those non-preferred tiers, there are always alternatives available in that tier 2 or tier 1. And so that's why they really try to steer people away from those. They're much more expensive drugs. Urgent care, you're currently paying a $55 copay. It's $50 under NAEBT. Emergency room, you're paying $200 if you're admitted, $200 copay, or excuse me, if you're not admitted, a $200 copay plus your deductible and coinsurance. Under NAEBT, it's a $150 copay. Those are both waived if you're actually admitted to the hospital. Let's see, mental health, outpatient counseling, they are charging just a straight $25 copayment for any outpatient, or excuse me, you're charging $25 copayment for any outpatient counseling, and they actually have that split between counseling and then counseling with a specialist at $30 and $50 respectively, just like any other office visit, so it's treated the same way. And then chiropractic care, you pay a $50 copay today with a 30 visit minimum, or excuse me, a 30 visit max per year, $100 maximum per visit. Under NAEBT, it's a $30 copay, and it's 40 visits per year, so a little bit better benefit there. And Teladoc, slightly different. They do offer Teladoc. Anybody on the gold plan today is not paying any consultation fees for that service. Under NAEBT, the first 4 visits are free, and then after that it's a $10 copay. They also offer additional services under Teladoc that the district does not currently offer. Those are dermatologist, behavioral health, and behavioral health with a psychiatrist. There are copays associated with those, 50, 30, and 50 respectively. So if you heard the presentation yesterday, significantly less than what was presented here if this trust were to add those services. On the high deductible health, any questions on that before I move on? On the high deductible health plan, it's a different plan. It offers both in and out of network benefits, and their deductible is not embedded. And I hate to speak insurance speak, but I have to because this is important. Under your plan today, you have a $4,000 individual deductible and $8,000 family deductible. Any member of the family who reaches that $4,000, it doesn't matter if it's you, a spouse, a child, that person's deductible is met for the entire year. That's called an embedded deductible. In a non-embedded deductible scenario, if you are not the employee, you have to meet the family deductible before your claims are paid according to the benefit structure. So in this case, their individual deductible is $1,350. Their family deductible is $2,700. So even though you'd have to meet that $2,700 if you're a spouse or a child, it's again significantly less than what the current benefit under NAEBT is. Or excuse me, I'm gonna get this so confused. Under Lake Havasu schools today. The other difference is that is not the maximum out of pocket like yours is today. Once you reach that $1,350 or $2,700, you then have to reach a max out-of-pocket of $3,000 for an individual or $6,000 for a family. So once you reach the $1,350, you start to pay co-insurance, like a traditional PPO plan, 20% on everything until you reach that $3,000. Questions on that? Any other questions you want me to answer on any EBT?
I would like you to go over the difference between, because one of our current plan, the Mayo Clinic is one of the hospitals that's included in our plan, but the NABT recognizes the blue card. I don't know if you're familiar with that, but it's a pretty significant enhancement compared to what we currently have on just the Blue Cross Blue Shield or something. Could you touch on that a little bit?
Sure. So Mayo is not a covered facility under the NAEBT plan except for transplants. Mayo does have an emergency room, and so obviously if you had an emergency where Mayo was your closest hospital, that would be covered in that event as well. Otherwise, it is not covered. But what they do offer is called Blue Card, and what Blue Card does is it gives you, as a member, access to any Blue Cross Blue Shield Anthem provider in the state, or excuse me, in the United States. So you could go to Vegas for services, routines, or it doesn't have to be an emergency. You can go anywhere you want in the United States as long as you're selecting a Blues provider that would be covered at the in-network benefit level.
So if you want to go to Vegas or California,
California.
as long as it's a blue network.
Also great for college kids. If you've got kids in college that are outside the state, it's an awesome option for them as well.
Can we get a hard copy of that at some point?
No,
No.
of course you can.
Okay.
I want you to keep it all right here, just like I have it.
Jamie, do we know how many employees currently use Mayo?
So I did not get that information back from, I got other information from Gilsbar, not that one. I do know it's your number 2 hospital, but I believe that's based on cost, not necessarily admits. I believe there was only 1 or 2 actual admits, if I'm not mistaken.
There were 2 admins, and I think they said it was 1 patient.
Right,
admin.
right, 1 patient with 2 admits.
Jamie, do you think it'd be helpful if we projected this? We could project it on the doc cam and they can see it?
Do we still have that?
What?
This rate comparison?
I didn't have that as part of my.
I think it was in the,
Mine from yesterday.
yeah, I think it's in the, it was in the presentation on NAEBT. Do you still have all the presentations with you? On the same thumb drive? If we have it, yes, we can project it. If we don't, I can send it to you. It was a little smaller, I think, in the presentation, if I'm not mistaken.
Yesterday, you mentioned the $75 fee for not participating in their wellness program.
Correct.
I did reach out to some employees because there was some confusion whether it was per month or per year, and they said it's per year as
Oh.
far as our city right now.
All right. That's good to know. I was not aware of that. That's unusual. It's normally a monthly
Yeah, it is
penalty,
monthly.
so, yeah.
Allstorm's looking for that. You want to touch on their wellness program a little bit, Jamie?
Sure. So they offer a robust, yeah, if you keep going, Storm, it should be like kind of down at the end. NAEBT offers a very robust wellness program. Oh, so it's not in there. I'm sorry. I'll have to send it to you.
I can put it on the document. I have it. I just.
Oh, yeah, if you don't have it, yeah, I'm sorry. Yeah.
I don't speak, I didn't know what that meant. The dot cam?
I apparently just like brushed right over that. I brushed right over that.
Nicole, it's right next to the mimeograph.
Yes. Yeah. So wellness, they offer a robust wellness program that offers on-site screenings. It offers wearable challenges. It offers, what else?
I don't think there's something seminars, but they do the wearable challenges, and then they have other challenges, I believe, built into their platform.
Right, So they're actually using a platform through Ameriben, their third-party administrator, and it offers them the ability to do various wearable challenges, step challenges using various devices, Fitbits, Apple Watches, whatever you have, Garmin's. And then they offer, again, all the on-site screenings. They're offering health risk assessments, they're offering skin cancer screenings, flu and pneumonia vaccinations, cardiac and organ screenings,
Comprehensive eye exam.
comprehensive eye exams. All of those things are brought on site. People can take advantage of them at various locations throughout the city. And so with that, Amy alluded to the $75 penalty. Right now, they have a rule in place, basically, if you want to call it that. Any employee who doesn't go through the health risk assessment is charged a $75 annual penalty for not completing that process. But as part of that platform that they're on, as they participate in various screenings, challenges, things like that, they actually earn points that they can turn in for prizes. So,
I'm sorry, Jamie, that only applies to the employee, not to any dependents that are also.
the $75 penalty only applies to the employee right now. Now that may change in the future. It's kind of the wave of the.
And the NABT also has an EAP plan in place.
They do. They have an employee assistance program using EAP Preferred. It's a 6-visit model. I know we've talked extensively about EAPs in these meetings in the past year in particular. So those are obviously free mental health visits that are offered to employees, their spouses, any members of their household as well.
And that is something that we put out for bid, that we have the information. It was not included in our presentations yesterday because we didn't have the rates yet. So, and I think when we got those numbers back, they were somewhere between $1.50 and $5 or $6 PPM per employee per month. So that's in addition to the rates that we were looking at yesterday. So that's adding everything else.
That EAP, it includes mental health, but there's other benefits, correct, like legal advice and such?
Absolutely, and I'm not intimately familiar with the EAP Preferred model because I don't use it on any of my accounts right now, but all of those EAP programs offer work-life benefits.
Right.
Most of them include a free 30-minute legal consultation, will preparation, tons of amazing resources on I haven't seen a website yet on one of these EAPs that is not phenomenal in terms of, you have questions about elder care or child care or, pet resource, any of that kind of stuff. You can go on there and it's just a wealth of information, so.
And that's already included in theirs.
Yes, yes.
And then a few of the other things, we would be required to, it's a 3-year minimum that we would be included in the plan, unless if you wanted to get out, there's a penalty.
Correct.
To bow out of our program. But anytime you join a group like that, a self-insured group like that, requesting to terminate or get out of the program in less than 3 years is just really not a good idea at all. One of the things that we know as far as if we terminated our program,
If we terminated this program, our trust, after the wind down and finalized all of our claims and whatnot, we did verify that any balance of any dollars would go back to our district. That money doesn't follow the lives per se. So the dollars are district dollars, and we're gonna find out where that went. But it's LHUSD, they're LHUSD dollars, so they don't go into a new trust. But the advantage of going into a new trust is that there's no buy-in.
Correct.
So we're not paying to go into that. All of our information, all of our claims information, they vetted, the NABT vetted our group just like any other group. And this trust, the NABT, is looking actively to add members because they want to become a larger trust. I think their focus, if I remember correctly, is they're really focusing on, the Northwest rural rural Arizona areas. I don't think they're particularly interested in bringing in, you know, the metropolis of,
No,
yeah,
doesn't make sense.
doesn't make sense. And they're very familiar with, you know, the providers in rural areas and whatnot. They're subject to the same open meeting laws that obviously we have. One of the things that is different that would be a change for us is that the trustees on the NABT that would be representing us would be, typically it would be this, our superintendent and then a backup, which is most likely the business director, that kind of thing. So our district would no longer have an employee benefit trust for itself. We would be part of we would be part of a larger trust, but we would be represented equally, just like every other entity, and we would have a voice at the table. So I think that that's definitely an advantage, and the bigger advantage, obviously, is knowing that we are part of a larger group. One of the really nice things that I think attracted me to even looking at it, number one, the fact that we were given an option, or, you know, given a bid several years ago. We had asked for this, and of course they were like, thanks, but no thanks. But when we received this offer, it was with all of our bells, whistles, and, you know, freckles and whatever. But the nice thing is that in 3 years, our rates will be looked at and our claims. And so as we continue to get better in our rates, because we're part of a larger group, our rates, you know, could theoretically change for the better. This group, I think we asked Mike Shunning yesterday, the actuary, who's also the actuary for the NABT, and that's one of the nice things too about the familiarity is there's a lot of the same people, but I think he said that over an average, and I don't remember how many years he was talking about. 7 years. The lowest rate increase was actually a pass, meaning no rate increase at all, and their highest was 8%.
Yeah, average is 3.5.
Yeah, and this year's is, they're looking at what, two?
Yeah, the range this year is 0.04 to 2.4%.
Yeah, and compared to, I think ours in the last 3 years is, what was 24, 10,
24, 10, and
15. So you can see that, you know, volume, number of lives, and then the active, robust wellness type of a thing. I think that those all have real advantages to keeping the rates in check. So again, I think, you know, having an opportunity like that to be proactive on something like that, I think is definitely an advantage.
When they talk about the rate increases, is that for employee only? Do we know what the retiree rate increases have been?
That's across the board. They were averaging 3.5%. Over the 7 years, the average is 3.5%. And really the way the premiums get created in a pool like that, Mike Shunning, the actuary, takes the total number. This is how much money we have to collect for premium, and then he allocates it among the plans and the tiers. And so really all the tiers get about the same increase, kind of like what you see here.
I'd also like to mention too that the rates we're discussing today for us would go into effect 1 July of this year. And if this board recommended going forward to the governing board, and if they recommended approval, the NAEBT would also go into effect 1 July. So that'd be pretty seamless also.
Were we able to get clarification as to what fund the money would transfer into?
And I think that's one of the things that we're trying to make sure that we don't have this break in confusion and whatever, you know, just like Hal said, having the, you know, the continuity, and we're, there's gonna be a meeting, a special meeting, I don't know if it's called a work session, a special meeting, but on Monday, for the school board to discuss this, and, Aaron, is it Aaron, is Stephanie gonna be there too?
No, Stephanie has another meeting, so it's Aaron.
Aaron Collins from ECA will be doing a presentation for the school board on based on our recommendation, and then he'll do the presentation. So our meeting today is really to just make sure that we go over this, our board making our recommendations as part of our renewal, and then taking that forward to our board, and then putting it in your labs, putting it in the board's labs.
We had a question,
what-
we had a question at our table about, other entities that are involved with the NAEBT.
Okay.
With the city,
Lake Havasu City, Bullhead City, and the city of Kingman.
Just school districts or the entire?
Just the city.
Just the
Yeah,
city.
just the cities.
Currently the NAEBT is made up of the 3 cities.
Okay.
But part of their marketing material, and we can also put a copy of that up on the website, they have sort of a brochure, marketing material kind of thing that said, I think it was beginning in 1920, they're making an effort to increase their numbers in the trust, so to speak. And they're not limiting it to cities and school districts. They're just going, they're looking for minimum size, I think, is 100, which a self-insured plan is, I don't know that I know of any that are 100, but rural areas, northwest Arizona, or our areas, rural areas. I don't know, yeah, it's not necessarily just cities and just Mojave County now. Yeah, so it could be, I don't even know what other big fire districts or something, I don't know what else.
Could be fire districts, other school
Other
districts.
school districts, yeah. But then again, like you said, each entity would have representation on their board. And they have, declaration of trust documents, bylaws, same thing as we do, except they have bylaws, and our current EBT doesn't have that. The other thing is that, we have rates, something that is different than, our current plan is that there's, they have an employee rate, and then the corresponding dependent rates, and then the retiree rates are separated out. And this is one of their requirements to have the, I'm not quite sure how they exactly put it, but it was self-sustaining, I think was the correct terminology. So that rate is pulled out of the whole. So those numbers are separated out, and then we've given those to Mr. Murray, and so I just want to make sure that you know that those numbers have been separated out.
what is the difference?
The retiree rates are significantly higher because they're based on the actual anticipated risk, based on the claims that the actuary looked at.
Do we have an approximate value, or?
I don't have it in front of me. They
I
are.
think I saw it on the slide when you were scrolling through the
Oh.
Is it gonna mess that up?
We can just get out of that.
I'm like, I don't know about that.
What did you call it? A dot cam?
If you touch it, it's going to blow up. No.
It probably would.
I don't know
Reminded
if
me
you
of
just
that,
touch those things.
Thank you.
Keep in mind too, though, that when you're looking at these are raw numbers, and so, I mean,
Just
obviously.
approximate, I'm curious. what
Sure,
the difference
absolutely.
is.
Yeah.
Storm, unless you updated that slide
I didn't.
presentation. So I've got a different thumb drive, sorry.
Yeah, special number.
Special.
Jamie, can I pass this around? Do you want to see it?
Yeah, absolutely.
Jamie,
Yes,
do you want me to speak to the dental vision at all, since I know?
that's up to the chair.
I'm pleased to, just because I know I've got that info.
Marsha, do you want him to talk about dental
Well,
vision?
can I ask one more question while we're getting that other info? It relates to that.
Yes,
Just since this is different, I'm not just, so a different price for retirees, but is there, the retiree dependents a different price, or are they the same as the dependents?
They're also, so it's an entirely separate retiree rate structure for each tier, so retiree only, retiree, spouse,
So the
retiree.
dependents for the retirees would also be a different rate than the other dependent
Correct.
rates?
That's correct.
The coverage,
So there you go.
plans are the same, the coverages, yeah.
So here, this is what the rates are currently in the gold plan and the high deductible. This is NAEBT's rate. This is what the rate would be under the plans for 2020 if the district stays self-funded on its own. So again, you can see, I mean, here we're talking about $2,100 for family, $2,920 is the actual rate for a family. And you don't have many that have family coverage. Most of them are retiree only and or retiree plus spouse. So I would focus probably more on those.
Well, I'm in the retiree, dependents, so.
Yeah, so there they are. So it's the two, and these numbers have not been adjusted yet for any of their changes that they may make 7/1. They'll know that in 2 weeks when they meet for the same meeting. But again, they're looking at an estimated 2.5% maximum on that, so not a huge difference than what you see there.
But a big difference from what they're doing now.
Correct, yeah, so again, you can see a retiree only right now is $719 under the current plan, and it would go to $1,073.18.
Is that a monthly
That's per month.
value?
Mhm. And just so you know, one of the things that you guys show differently when you look at your rates, you don't actually include your employee only or retiree rate when you're looking at your dependents. So this number here includes this.
Right.
Yeah. So I just didn't want you to think it was 2,000 plus 1,000.
Oh, no, I
Okay,
knew
good.
that, I just was
Yeah.
seeing the difference.
Mhm.
Yes,
Does the NAEBT hold public meetings like the ones that?
of course, absolutely.
Do they go take place in Lake Havasu, do they take place elsewhere, or do you know?
They rotate. So they rotate among each city.
They are a trust and they're subject to all open meeting laws, just like the other, yeah. Can you scroll to the employee rate sheet as well? You can see that.
So here's where you start to see savings in most of the tiers. Not tons, but a little.
So you can see in the first column, like, that middle line, the 2021 goal, that's what we're looking at for our renewal.
Right. So yeah, when you look at what the trust is facing for 2021, it's a larger savings over the NAEBT than what you're paying today.
And then if you just go one line up, then NABT, EPO. Now, the one thing that is, would be factored in there is that doesn't include the dental and the vision, so you probably add another $40 to that. But still, you're looking at that times, how many, 400 or 500 employees?
I did put the dental and vision rates in here, by the way, if you want to look at those.
Sure. But that, and I guess the take-home message for me is that even adding that in, you're still looking at, pretty significant difference overall. And adding our number of employees, our number of lives into a larger group like that, and going forward with, and there are some pretty significant differences as far as I could tell anyway in the benefit structure. Having the EAP already in there, the wellness plan already in there, and from my experience, 42 years experience of this, in medical insurance and whatnot, and 10 years in the wellness industry and whatnot, going into an established wellness plan that has history and already going through the hiccups of, gosh, that didn't work at all, and this is really neat, and we can do this, and and going into a veteran program like that really does have some credence and value to it. I've worked with organizations that we're going to do this, and we're going to have 50% of our employees are going to have they're going to have outcomes, and it just doesn't work that way. But when you've got a group that has a lot of experience in doing wellness programs and has a lot of history with it, it really does have very better than average outcomes, I think, for the people going into the plans. Do you feel like that's a true statement?
Well, yeah, depending on their group,
so, and I think just, you know, again, being part of a larger group, and it comes down to numbers. And if you're in a group of 4,000 or 5,000 versus 800, just, you know, spreading the risk apart or around. And we've had this conversation so many times, it's, you know, it's like everything is in a bucket, our bucket has a hole in it, and we just can't keep it filled. And when we have a significant number of claims, and our catastrophe claims are just, you know, they're eating us up. And we've got these, you know, extra lasers on our stop loss, and we can't get ahead of them. And when you're in a larger group like that, you can. And not even just catching a breath, but, you know, at some point in time, looking forward to being able to get ahead of it, you know. But, so.
Then even if you factor in a 2.5% to the any EBT figure there, it puts it up to like 1,920, but compared to our projected rate, it's just under $200 less with the NEBT, even with a 2.5% increase, $194.98 different, even with the increase to them.
Do we have any other questions on those premiums at all, or Rich, do you want to touch on the dental?
Okay, Marcia.
Yes, oh, sorry.
Madam Chairman, I just wanted to, not really a question, but I kind of wanted, I feel like the elephant in the room should be addressed, because really it's going to be a retiree question.
Sure.
And I think that's what are on a lot of people's minds, because everything else makes financial sense. But, you know, obviously it's higher for the retirees, but I just wanted to make it clear for those that might not understand, that isn't for this board. That's going to be something that our board, unfortunately, is going to have to, you know, speak to. But I wanted to just say how much I appreciate everybody that's sitting up there, because this is, you know, to even have real information is such a new thing for this district, to be able to sit and have this kind of meeting and actually make decisions based on real numbers it's still new to us. And
having it in February.
Right, right.
Not April.
And actually having choices to be made, and the benefits that are offered, just based off what I read and heard yesterday, I didn't see where there was a loss of any actual benefits to anybody while the retiree is going up. That obviously has to be addressed, how it's not gonna happen today. But just having more buying power is always gonna be a good thing, even for our retirees. It's going to be a good thing, even though there may be a hit. This is just my opinion. And it allows us to speak about what's truthfully going on with our health care. And I just don't want anybody to feel like, you know, this is a loss for them, because this is good. This has taken many years and a lot of hard work from mostly Marcia sitting there. And I appreciate everybody who sits up there. But the bottom line is, we're not experts in education, even though Marcia has an expertise in it. And to continue maybe to even have this meeting and rely on people like Dr. Atassi, which I'm sure there's somebody that could use heart surgery right now, is not the best source of our time either. And it's very emotional. And so I just wanted to say how much I appreciate that from both sides. Because I know people, you know, it's freaky when your medical insurance is going to change. And so I just wanted to address that, because I know there's people in this room thinking that right now. And I'm empathetic about that, for sure.
Nicole, no offense to Dr. Atassi, but someone might be looking for a commercial building right now, too.
But nobody's going to die waiting to find that building.
Not to hear from the people I deal with.
Yeah, they actually. Well, I appreciate that too, and I know that, you know, and again, this is, you know, it's been, I think Hal and I mentioned this yesterday, it's been like 5 going on 6 years of, you know, another, and again, and we found another one yesterday of, you know, why psychotherapies and the speech therapies, and it was like, another one? What? You know, and, you know, I've got 32 pounds of binders and books at my house that I wish I never had to look at again, you know, but that's what you do. You keep looking and you keep digging, and the benefit is that, we wanna make sure that we've got knowledge to make an informed decision, and that's what you have to be able to do, because we wanna attract, you know, teachers and employees to our district that wanna stay here and retire here and, you know, raise their kids and their families here, and, you know, as someone that's lived here for 30 years. And having that information is, you know, you have to have the information to make an informed decision, and, for a really, really long time, it was just like, let's just snowball this, let's just, you know, throw it out there. So, we're trying to do the best we can, and we appreciate all of that. So, do we wanna talk about,
Yeah, I
Gail?
can help because I have the opportunity to serve on both trusts. Madam Chair, if I get up here, Rich Hanna with Emeritus, for those of you who didn't get to see me yesterday. And I'll speak to a very high level, and Jamie, ETA, anybody please chime in from what you know of NABT to be different. But in general, looking over the dental benefits from a broad perspective, fitting for the trust, network driven, as mentioned yesterday, of 99.6%, I believe it was, in network utilization. Theirs is geared in the same way. They don't have an out-of-network benefit. In general, their maximum, I believe, is a $3,000 benefit compared to your current $2,000. And again, speaking to today, this can always change in July depending on what the trust decides to do. They do have similar co-insurance setup. They have 180/80, so a higher major co-insurance allowance, a potentially lower restorative co-insurance allowance. They do not have the incentive, the wellness program you have that goes 80, 90, 100 the tiers. So in general, overall, I would say it's comparable, if not a potential enhancement to the benefit program you have today. And speaking in a larger term setting, they do also have an ortho benefit. Again, that is not the entirety of the plan, but a broad overview for the room of kind of the enhancement they have. An implant benefit, which I don't believe you have today, so there's definitely some intricacies, some detail within that, but a broad overview. I think it is at least comparable, if not an enhancement to what you have today.
And can you talk to, when you go from an existing plan to, like from our current dental to the other, do you get a carryover on already meeting, like for restorative and major, or does it start all over again, like for the waiting periods and whatnot?
Sure. So I can speak to broad general terms in that of how we would handle as an administrator. Otherwise, as your administrator with the advisement of the trust and your consultant, we can really handle that how you wish, how an EBT wishes to come in to the plan. So again, I think that's all negotiable. In general, if we were to start on a plan year, we could roll that to be a completely new. You would start over July 1, or we could roll it to carry and start over January 1. Again, Jamie, I don't know if you have any insight into.
I thought they were on a fiscal year deductible already, and I believe the district is also on a fiscal year, so you would start over just like you normally would July 1.
Yeah, so assumably if that's coinciding, we would just carry that forward, so July 1 would be a start over for all.
Yeah. And I think also in general, just broadly, for even related to medical, you know, everyone needs to know that, you know, pre-existing conditions go from one plan to another, you know, that doesn't, there's no issues. Because we're way past that with ACA and whatnot, so you don't have to worry about those things. So,
And I can give an update on the vision as well.
Okay.
Like Madam Chair, a quick update from listening to James's presentation yesterday with UHC. Again, similar benefit. I can't speak to the difference in the network specifically, but UHC versus a VSP network. The benefits are 12, 12, 12 for each, so the frequencies, the availability remain the same for the plan you have today in the current plan with NAEBT. The allowances are 105 and 150, so your allowance structure is, again, potential benefit enhancement going from $105 up to 150. Again, general overall theme, comparable if not the benefit enhancement for the overall, depending on the view of the network.
and then VSP had Riverview, I think? Was that what
up all, you know, all of the, yeah. So that would have been that on. Did anybody have any other questions about the division or the dental in general?
This is, I was up on stage for 10 minutes yesterday. I appreciate you all entertaining me here for 11 today.
Well, we wanted to make it worth your while so you could write this on.
Thank you.
Thanks.
If there's no other questions, I make a motion to close discussion.
Dr. Otasi?
Yep.
Amy Barney?
Yes.
Paul Christensen?
Yes.
Marcia Cox?
Yes.
Julie Sassine?
Yes.
Okay, then, you have
Do you want to make this motion or do you want me to? So I make a motion to recommend the district join the NAVT, and then because of the recommendation that trust be terminated and wound down per the trust agreement and statute section 13.01 of the trust document.
Okay.
Dr. Toski.
Thank you. Dr. Otasi? Amy Barney?
Yes.
Paul Christensen?
Yes.
Marcia Cox?
Yes.
Julie Sassine?
Yes.
So with that, there will be a meeting on Monday again with the school board, with the presentation made by Aaron from ECA to the school board. That's a special meeting, so the discussion will be amongst, pardon? Work session, sorry. Did I say special meeting? It was, I had a 50% chance.
5 o'clock?
It's about
5 o'clock
5 o'clock.
Monday? Monday, okay.
5 o'clock Monday. And then would be followed up at the school board meeting, the regular school board meeting on the 18th, I think. Okay. And then subsequent to that, and not obviously having a crystal ball and knowing, well, I do have a crystal ball, no, I don't. But not knowing what those final decisions are, our further action items are all contingent upon the district making a decision to vote to join the NAVT. So the balance of our agenda items would be to go over our renewals, and so the process is then the DBM. Oh, we have to do that first. Sorry. Back up. Sorry, it's okay. So item 4.3, update regarding PBM request for proposal. So make a motion to approve update regarding PBM request for proposal process.
Second.
Dr. Otasi?
Yes.
Amy Barney?
Yes.
Paul Christensen?
Yes.
Marcia Cox?
Yes.
Julie Sassine?
Yes.
All right, so trustees asked ECA to conduct a request for proposal for pharmacy benefit managers, really just to see if we could get a better deal than what was being offered in the National Cooperative using CVS. So we sent requests for proposals out to Navitus, Pharmastar, ProAct, and SmithRx. All of those responded to the RFP. As part of that process, we sent each of those companies 12 months of actual prescription data and asked them to reprice those same claims under their systems for those same dates of service, same pharmacies, et cetera. And when we took a look at all of the numbers, and I will tell you, I'm the first to admit I was very surprised by this, but actually the current vendor, National Cooperative, came in less. So based on that and based on the additional things that we had going on here, I had a conversation with the chairperson, and we made a decision not to pursue this any further since it didn't make financial sense to do so. So this is really just an FYI for you that that process did happen, but we've elected not to go further with that.
It's a good thing I bought coffee today. So our subsequent discussions obviously are the, because we don't know what is gonna happen at the school board meeting on the 18th. So we do need to go ahead and continue our discussions for renewal and make those decisions. And obviously, any of the decisions that we make regarding our renewal will be contingent upon the school board making their final decisions. So we do need to finish out and review the information for the balance of that agenda item. So the next item is 4.4, discussion and possible action regarding TPA contract award. So we have a motion to discuss possible action regarding TPA contract.
So moved.
Second.
Dr. Tossi?
Yes.
Amy Barney?
Yes.
Hal Christensen?
Yes.
Marcia Cox?
Yes.
Julie Sassine?
Yes.
All right, well, thank you, Madam Chair, trustees. Again, as you all know, we also took the third-party administrator out to bid, and that was related in some part to some customer service issues that were being experienced with Gills Bar, but it also was really just a market check to see sort of where the rest of the market stood in terms of third-party administration. We sent RFPs, I don't have my other thing, we sent our RFPs out to five or six, seven TPAs approved by Blue Cross Blue Shield of Arizona. We got 5 responses back. Of the 5, I'm sorry, it was 4. We interviewed 3. We threw 1 out kind of right off the top because their pricing was a little wonky, a lot of hidden fees, and a lot of deviations to both services and contracts. So we interviewed 3 firms, Gills Bar, which is your incumbent. We interviewed Ameriben, and we interviewed Health Now, right? Health Now.
Summit, yeah.
Summit. Health Now is who we threw out. I'm doing these simultaneously, my apologies. Following those interviews, I was directed to enter into best and final negotiations with Ameriben. And following that negotiation, I was able to get some reductions that overall make Ameriben the best candidate, qualified candidate for third-party administration. Basically, when you look at the consolidated fees over the course of 5 years, which is what those contract terms are, Ameriben came in at $609,827. Gills Bar was at $728,052, and Summit came in at $677,288. They also offered some savings on out-of-network claim negotiations, subrogation, printing and mailing. We went through all of the details. Originally, Ameriben came in at $20 per employee per month for their claims administration. They agreed to drop that to $19.50 for the first 3 years, and then a max of 5% thereafter. So we did do reference checks. I got 3 reference checks back from current clients who had glowing recommendations, nothing negative to say. I'm happy to share those specifically if you'd like. We also had 2 former clients who responded to our request for references. Both said they would rehire Ameriben in a heartbeat if they could. They had gone to either fully insured programs or they had gone to a program where they were acquired by somebody else and therefore didn't have a choice any longer of who they could use to serve their accounts. With that, it would be our recommendation that if the district does not enter any EBT, that we would award a contract for services to Ameriben effective 7/1/20.
Jamie, isn't it true that Ameriben is the TPA for NABT also?
That is correct.
And you've worked with them?
I've worked with Ameriben for about 8 or 9 years now,
Okay.
On various clients, obviously.
Right, thank you.
Something I also really liked about Ameriben was that they have an ESOP, employee stock option ownership, and they've had that, I think, for 5 years?
Maybe 2.
2, okay. But to me, that really speaks volumes, and the fact that they're from Idaho, I think, Boise, or something like
Boise,
that.
yes.
Yeah, and they
In
work-
Salt Lake City.
Yeah, and they work with Simplot Spud Factory, which is where my husband used to sell our potatoes when we were farmers. I thought it was kind of, but anyway, just to have an employee, a stock option ownership, And one of the things that Audrey said, was, when you pick up, when you call and somebody picks up the phone, you're talking to an owner. And to me, that was just like, I love that. The other thing, they're on average, their claims analysts and representatives have been there for 5 years, and they don't let anybody on the phone, or they don't let people, processing things unless they've gone through their very extensive in-house training, and they have to be certified and whatnot. So for me, looking on the billing side, that makes a lot of sense to me. And the other thing that I really like is they have their own unique software, and I guess it's proprietary, it must be proprietary, or maybe it's not, I don't know, but they have this very live, real-time analysis program that they can track things and kind of see, why are we seeing claims in this area, or why are we seeing jumps and spikes and things. And so whether it's with our current plan or with EBT, having the benefit of using Ameriben, I think is just going to be just a real plus.
A couple other things I noticed in their presentation, they said that software program helps save an average of 10 to 15% of claims when they came in, I think it was. And their call center, everybody's cross-trained so they can handle over 90% of the calls on the first call. They can take care of your issue.
In the interest of full disclosure, I would like to let you know that we just learned that Anthem has acquired Ameriben effective March 1st. So they sold the ESOP, they sold all the shares. However, and I'll let Kelly speak to this, Kelly from Ameriben is here. However, they are allowing them to remain fully intact. All of their employees are staying exactly in place as they are today. Their culture is remaining, computer systems are the same. So they're just becoming a subsidiary so that they can provide TPA services to other Anthem clients.
Do you want me to come up and speak to that?
Absolutely.
Thank you. Good afternoon. So yes, as of last Wednesday, we found out that Anthem has entered into an agreement to purchase the Ameriben shares. This is going to go into effect March 1st, and this was something that was not entered into lightly. We had entered into an ESOP in October of 2018, and really what it was intended for was a retirement vehicle for the employees. It wasn't until January that our leadership team learned that Anthem was interested in purchasing Ameriben. But Anthem it was rumored, so Anthem hadn't made their intent known to us. And so at that time when the rumors were going around, our leadership team, Carrie Hatch, John Aubrey, our legal counsel, Brian Hall, and our CFO, Eric Channer, they all attended an ESOP conference. And they did that to gather information about what happens, what would happen, can we dissolve it? Every ESOP is assigned a trustee who is the fiduciary of the ESOP. And that fiduciary has to put out the motion, and they do have to view and look at every offer that comes in the door and make the determination, is this what is best for the employees of the company, and is it best for the company long term? So during that process, it wasn't until June where Anthem came into Ameriben and said, this is what we want to do. We are looking to buy a TPA. We want it to be Ameriben. And we have a very strong relationship with Anthem. And we really, it made the best sense for Anthem to buy Ameriben, as much as the employees didn't fully understand it when it was explained to us on Wednesday. What it does is it opens up a lot of opportunity for Anthem and for Ameriben. Anthem has committed to Ameriben that we will remain independent. We are a subsidiary. That's it. We're not going to be changing our name to Anthem. At some point down the road, employees may be rolled into the Anthem Employee Benefit Program, but right now we are remaining Ameriben. We will retain our leadership team. The only change in reporting structure is Carrie Hatch, our CEO. She will report to someone at Anthem in Indiana. but she will retain her leadership team. We will retain our legal, Brian Hall, he will remain within our company, as well as our CFO, and we'll be operating as we have been. For the employees, it's actually a good thing. It really is. We had a call the next day on Thursday where Carrie answered a lot of our questions and talked about the timing of it. And of course, we all had questions about, I thought we could never be sold. And the thing about fiduciary is, again, they have to look at what's best for the employees and the company. We don't get a say in that. If they had turned down the offer, which actually didn't take place until September, then that could have affected our shares in the future and the ability if we ever did want to sell. So that was really kind of how it went down. Are there any questions I can answer for you all?
So the rates that you proposed to us are still valid?
Absolutely, yes.
The people assigned to us are still the same people?
Yes.
So because obviously one of the things that, attracted me, and I'm sure the other members that, had an opportunity to listen to you were, family comes first, community, business, that kind of thing. I mean, those are your model is still the same right now because you're a subsidiary, you're not being folded in. Obviously, Anthem was looking for a third-party administrator and they wanted somebody with your model.
Absolutely.
I can see why they would, want to purchase Ameriben.
Right, we have a very strong relationship with them now, and there's no reason for them to want to change what we're doing. They bought us because of how we do it. They bought us because of our culture. And that was one of the things that really intrigued them, is our culture. And they've committed to us that that will stay in place. They're not going to come in and mess with that. So in fact, we might teach them a few things.
Yeah, you just built a really big building. You just, you're gonna keep that? No.
Yes.
So, and, I mean, I would expect that you're not gonna be making any, changes short-term as far as how you're processing things, and like Amy said, your turnaround, you give your employees autonomy to make decisions, and, and again, that was one of the things that I think that, impressed all of us was, you give your employees the opportunity to, follow through and make some decisions without having to wait, and, I gotta get back to you because I gotta talk to somebody, get permission, kind of a thing.
Absolutely. Our infrastructure will not be changing at all. Again, they bought us because of how we process claims, and so they're not going to come in and change that.
I'm a positive person, I'm also a cynic, and I was in banking for over 30 years, and I can tell you that every single bank acquisition I went through or aware of where they said, everything's gonna stay the same. Not true. And I'm just saying that, it's just, as it goes forward, there's always, someone may not be happy with this or do something else. So it sounds like a good deal, and Ameriben appears to be, they're gonna continue doing what they're doing. But when someone tells you everything's gonna be the same,
No,
I don't think so.
No, there's always going to be change whether we
Yes,
remain
exactly.
myself or not.
Yeah.
As far as how I view the Anthem acquisition is, I think it's a positive for us. Not only does it strengthen our relationship with Anthem, it also strengthens our relationship with Blue Cross Blue Shield of Arizona.
Yeah.
Because now we're kind of a blue. And so there's more opportunity there. When that will take place, we won't probably see anything for probably another year and a half. But definitely opportunity.
Thanks. I don't know if I can make a dual motion to close discussion and approve, recommending, or, awarding Ameriben the, effective July 1st to be our new TPA for the trust. I don't know if I can do it, but I can.
Well, we didn't do an open and closed discussion, so we just.
Close discussion
Contract.
and
Yeah.
approve the contract.
Just a reminder though that the motion has to be, has to include language that is contingent on whether or not the district joins any
Everything
EBT.
going forward needs to include contingent on the district's decision.
On each item, even though Marcia said that, okay,
No, I think we get it.
okay, all right,
I'm clarifying for the record.
gotcha,
It's
okay.
on video too.
That's
Yes.
right.
I think we're safe.
Second,
Dr. Tossi,
Yes.
Amy Barney,
yes.
Paul Christensen,
Yes,
Marcia Cox,
Yes.
Julie Sessie.
Yes.
We have a motion to discuss and possible action regarding the wellness proposal.
so moved.
Second.
Dr. Tossi,
Yes.
Amy Barney,
Yes.
Paul Christensen,
Yes,
Marcia Cox,
Yes.
Julie Sessie.
Yes.
Yeah, so you can pass those out, and then I'll need one too. So I'll just open up this discussion. We've talked a bit already about wellness programming as it exists through any EBT. One of the things that this board had discussed when we closed the clinic was bringing in a wellness program to this trust to sort of pick up some of those items that the clinic used to do. So with that in mind, Marcia had asked us to provide ECA to provide a wellness proposal for your consideration. As with the last item, this would be contingent, obviously, on whether or not the district joins NAEBT. I'm going to have Jamie Merlino, our wellness consultant, talk a little bit about. Did you leave mine?
Jamie, do we have this in the packet or not to put up on the board?
I don't. I'm sorry.
Okay.
But we have some extra copies if anybody would like one.
Okay.
So I'm just gonna start with a little history basically about how ECA got into wellness, and then I'm really gonna turn it over to Jamie to talk about what we're proposing, because it is a multi-year approach. And basically, in about 1995-ish, maybe 6, Erin was serving as a consultant for a group of rural communities, rural counties, and they started to see a major influx of breast cancer cases. And when we started digging into why that was happening, we realized that there weren't any local mammogram facilities in these rural communities. And so the Board of Trustees sat down and said, listen, we gotta get a handle on this. What can we do? Erin, what can you do? And so he in turn went out and found these mobile units that will come on site, Mom, and there's a couple of others now. And that really was how our wellness programming was born. Again, about 1996 or 7, I think it was. We've been doing it since then. We've obviously expanded on that quite a bit. We offer wellness programming to almost all of our clients currently. There are a few who don't offer it. We take a 3-prong approach to our wellness programming, and I talked about this a little bit yesterday. Preventive screenings, chronic disease management, and also lifestyle management, lifestyle behavior as well. And with that, I will turn it over to Jamie to talk about some of the specifics in terms of what we would propose for the trust, and we'll answer any questions you have.
Thank you. Like Jamie said, our approach is really based on prevention, so that's with the early detection, with our on-site screenings. We have the lifestyle and behavior change programs, so we have a variety of different programs that we've offered in the past, and that the groups are still offering for that. And then chronic disease management, so just preventing those current diseases or predisposition diseases like prediabetes or anything from getting worse. Main goal of all of the wellness programming is to reduce claims and save money for the plan, as well as improve the health of the members and have them healthier and happier lives. So if the board moves forward with implementing this wellness program and does not go into NEBT, I would be the consultant. We would do all the scheduling, contracting, finding vendors, evaluating the program, reevaluating it. We would be there the whole way, take care of billing, scheduling, all of that. It would be me and our wellness program support specialists, and we have a team in Phoenix as well. So then which is the multi-year approach. So we would want to start kind of to build the foundation and kind of start slow. So we want to just make sure that we have everything in order so we can develop the program in a smooth way and not just kind of throw it all out there. So that first year is really just going to be based on introducing the program as well as those on-site screenings. Year 2 is going to be building on those on-site screenings, implementing one new program that would be recommended. We would target the moderate risk members, and that could be through Fitbit platforms, wearable device challenges, wearable platforms, pre-diabetes programs, weight management programs. It just kind of depends on what we have in year 1, and we can go back to those results and data and evaluate to see what we need to be implementing in the future. Year 3 would be adding on 1 or 2 more programs, which would be either building upon what they already have or implementing new programs.
And by the way, I would just add, and she's gonna get into a lot more detail, but these are suggestions. This is how we find that wellness works, but our programming is flexible. So, you know, if this goes through and we're your consultant, we sit down with you and we say, okay, what really works? I mean, maybe a weight loss program isn't gonna work for you. So everything is fluid and flexible based on what the needs are of your population.
Yeah, we really do make a personalized program, and we work with the wellness team internally to see what is going to really work best. So for year 1, that slide right there, it says program development, branding, and on-site screenings. So I'm going to get into each of these a little bit more in the slides coming, but basically just focusing year 1 on developing and introducing that program. We're going to want to establish the wellness, the internal wellness team. So that's going to be the wellness champion and wellness ambassadors and the main wellness program coordinator. So that'll be that main contact for me to work with and provide the programming. That's going to be approving everything we talk about and yeah, just being my main point of contact for scheduling and everything. Branding, we're going to want to market the program so that it's easily recognizable. And then the on-site screenings, like I said. So the next slide, the program development. It's really important, well, we recommend to implement this wellness support team because we find it's really important to have that inside support and having the employees kind of walk the talk and be advocates for the wellness program. So they'll act as leaders within within their colleagues and be able to promote the program, distribute marketing materials, distribute information. They'll be present on site at the on-site screenings and programs to kind of show that they have buy-in, and so should the other employees. The wellness program coordinator, like I said, would be the main contact. So they'll hold the meetings and kind of be the leader for that wellness team. But then I will be there as well in the beginning to help establish that, and as they move forward with the program, it will be kind of like taken over on them, and they can do their wellness from the inside, and I'll still be a resource.
And so are you recommending a wellness coordinator at each school or one?
Just one.
Person?
Yeah, just one. And then it would be the wellness team would be like somebody from each location. Those would be the wellness champions or ambassadors. So for the needs and interest survey, this is something we typically do annually with all of our clients who have wellness. So this will identify what is going to motivate the members, what they want to see in their wellness program, what incentives they might be, interested in receiving, and then based on that, we'll kind of create the program. So create that calendar and the plan and the budget to be able to set the goals and really just create a program that is relevant to the group. If you guys have any questions at any time, you can stop me. For the branding, like I said, this is just to be recognizable. We want to be consistent with our marketing materials and information so that when employees see those, they can easily identify what that's our wellness program in. Thank you. Just an immediate association of that program. So we would do that with a logo. We've done like slogans in the past and then naming the program. For the on-site screenings, we would expand, or we recommend expanding on what we currently have. So there's the mobile on-site mammography and flu vaccinations. So we could also look into, there's the health risk assessment with nurse consultation. That's the screening that we really recommend to most of our groups. Healthy heart blood draw, that would be a 6 months checkup to the HRA screening. So that's usually geared towards members with health conditions or prediabetes or on any chronic condition or chronic programs. So yeah, we have that in a couple groups for like with our diabetes management. So the men's health screening, that is similar to the mom, where the mobile unit comes on site, and for other groups we do it sometimes yearly, every other year, but still just based upon your population and the need for that screening. We have skin cancer screening that Judy mentioned, because that's not covered by healthcare reform, so that's important to bring on site for people, you know, who live in Arizona and where, you know, we should be receiving that screening annually. We have cardiac and organ screening, so this one's kind of a favorite for everybody. It's an ultrasound test, so you'll get your carotid artery, thyroid, abdominal aorta, kidneys, gallbladder, liver, and peripheral artery ultrasound, and just to test for any like cysts, nodules, or abnormalities there. And we mostly see thyroid issues and high blood pressure with that screening. So we do catch a lot of weird abnormalities that we wouldn't catch otherwise. Eye screening, James from United Healthcare talked about this yesterday with the comprehensive eye exams and bringing that on site so that they have opportunities to get that done at a more convenient location. So that screening can detect diabetes, hypertension, high cholesterol, a lot of times before you know, so, and a lot more. So with those screenings, those are just kind of opportunities that we could look into and mix and match those. And we're always looking for new screenings and doing research on what's relevant and what would be necessary to bring on site. All right, so for the program expansion, so we would look at year one and go into the claims data and the results from the screenings, abnormalities come from the screenings, and kind of look at what health risks we're seeing across the population, and then base our recommendations off of that, take it to the board and say these are our ideas, what we think could be beneficial for the members to implement. And it would, like I said, for year two, we want to recommend targeting those moderate risk members and implementing one new program for them. And then in year two, going back, evaluating, and either building upon that program, starting to try something new, and then bringing two new programs that are going to also impact the high-risk members. So just kind of a step program to not dive in all at once, but kind of either way in. Examples of those programs can be the prediabetes, the diabetes management, like I said, the platforms, wearable devices, challenges, and other technology. Does anyone have any questions?
Is this similar to what NA EBT offers?
Yeah, it's similar. They have the on-site screenings. They have the wellness platform with the challenges. They've done seminars in the past, so very similar.
And these, this plan, the ratings, the rate for this has already been built into our budget for the.
That's correct. I don't have anything to add,
Okay.
unless you have more questions.
motion, we close the discussion portion and also make a motion that we approve adding a wellness program proposal to our existing benefits, subject to, if continuing with the trust.
Perfect.
This trust.
Second. Dr. Thompson seconds.
Okay. Dr. Tossi?
Yes.
Amy Barney?
Yes.
Hal Christensen?
Yes?
Marcia Cox?
Yes.
Julie Sassine?
Yes.
Item 4.6, discussion and possible action regarding employee assistance program.
Thank you, Madam Chair, trustees. I move to open.
Motion?
So moved. Open discussion.
Second.
Dr. Tossi?
Yes.
Amy Barney?
Yes.
Hal Christensen?
Yes.
Marcia Cox?
Yes.
Julie Sassine?
Yes.
Okay. Trustees also asked ECA to obtain quotes for an employee assistance program for the 2020-21 plan year. That sounds awkward to say. We sent out requests to 5 firms: Alliance Work Partners, CuraLink, which operates their EAP as Support Link, EAP Preferred, which is the group that an EBT uses, Holman Group, and Jorgensen Brooks. Each of those vendors provided responses to our request. All of the firms have the knowledge and expertise and experience to provide EAP services to the district. They all include robust websites. We talked about the work life, for example, earlier. All of those provide those functions. We did ask these folks to price both a 3-session and a 6-session model. And I did provide you with a summary of all of those responses. Unless you want me to, I won't get into all of the nitty-gritty detail. What I will tell you is that in terms of pricing, for the 3-session models, pricing is between $1.09 and $1.76 per employee per month. For a 6-session, it's between $1.42 and $3.19. So they're sort of all over the board there. We did ask them to provide us with a provider directory for Arizona. And for Lake Havasu City specifically, the number of providers ranges from 3 to 15. So again, happy to answer any detailed questions you may have. From my side, because the trust is facing a rather significant increase this year, it would be my recommendation not to entertain an EAP. However, if the board wants to pursue that, my second recommendation then would be to enter into some best and final negotiations with EAP Preferred and CuraLink that we could then bring back to the board for decision in April, which would still leave plenty of time for implementation if that were decided upon.
Go ahead.
Do we know what utilization was last time we had this?
I don't have that in front of me, but as I recall, it was about 2%.
I remember one of our former trustees brought that up, and based on the cost and utilization, that's, I think, when the board decided to eliminate the EAP.
People that are using it.
Right.
Right.
So, because that, per employee per month goes across the board with everybody.
Correct.
And a 2% usage, it really doesn't make, I understand for the 2% of the people using it, it's important. But overall, for the trust, I don't think it'd be responsible to
Well, I also think
have the EAP.
this came about because of the need for mental health services, and now that we're offering that at copay, it kind of takes some of the need of this away.
Right, I think that was the main focus too. I mean, we know the EAPs offer things in addition to that, but for an interim stopgap, I think just knowing that, like you said, Amy, having that is with that copay and, eliminating that deductible part of that, I think it's a good option. And the pricing on that was like 0.1%. It wasn't even a penny per month kind of thing, so I think that would be.
And when we talk about some of those work-life things, the life insurance carrier has a lot of those things.
Right.
So there are other options to receive those types of information and benefits outside of the EAP as well.
Right.
So if we do continue, is there a way to make that known?
Absolutely.
And we do have, and I think, Mr. Murray, I think it's in that list of
how-tos, go-tos kind of thing that I gave you from the National Association of Health Underwriters that gives sort of guidelines on, you know, how to buy insurance and whatnot.
I'd have to review that again.
Yeah, I'm happy to go through that with you too, because those are free, limits and how-tos kind of things that come from different associations. And they're always, well, you know, more than happy to let you look at all that. So, but I think that is, you know, because of the significant change in premium, I don't think that this would be something that I would particularly be interested in adding.
Comments from anybody? Go ahead.
I have one. Do I have to give you my name? You don't care about the way I'm doing.
No, I do want you to stand up and give your name and come on, so we can get you. So the microphone can pick up your voice and the recording.
I have a very loud voice. If my students can hear me, I know this room can hear me. Okay, I'm Catherine Hubert. I'm Ora Grande. Just really quick, I don't think the EPA was really publicized very much when we had it before. I just don't think the information was out there and employees were aware that that benefit was there. Yes, you sent emails. I received emails. I knew about the benefit, but I really don't think a whole lot of people knew about it. And there was a stigma on mental health that I feel it's not as taboo now as it used to be. And I think people who would not get the help before are more willing to get the help now. And I feel our district needs to look at that because that is important. The mental health of all of our staff and of our staff's family, that's important. That keeps us working because if you're not mentally okay to work, you're not going to be there. That's not what's best for students. That's not what's best for families. So, thank you.
And I think the really cool thing about that is because we're changing, correcting, right-sizing that in our benefits because we found that mistake. I don't know if it's a mistake. We found that carve out, if you will, and fixed it. It's going to be just subject to a regular office visit copay and not have this deductible thing attached to it. So, and you're right, I don't think it has the same stigma it did 10, 15, 20 years ago. But I think we did it. I think we did right by all of our members by fixing that. Carol, did you have a question?
Well, you just said it because I know yesterday we did say we stayed with the EBT that you were going to.
Same rules apply, dear.
Carol Narkowski, certified staff member, LHUSD. Yesterday, you said that if we stayed with the EBT, that we would, as is, we would work on covering psychotherapy. So I'm just getting here, so have we discussed that with this new possible plan that would be
The new plan.
covering copay wise?
Yeah, are you talking about the NABT?
Mm-hmm.
NABT has an EAP plan in it already.
Okay.
It's included in the,
I just missed
It
that
also
information.
covers psychotherapy.
and it does cover psychotherapy.
Okay, because I know that was part of something we were going to discuss if we stayed with the trust.
Right, and so yesterday, that was one of the, and that's what I was alluding to today, and I think I also did yesterday, was, you know, we started with thousands of pages years ago and finding all these, and some of them after ECA became our consultant, and then being able to, you know, call some of our vendors, it's like, we did what? We found what? You know, some of those continuous conversations, and that was one of the, why did that happen? And we found out that we had a psychotherapy carve-out, just like a physical therapy, you know, subject to the deductible or speech therapy. And it was just one of those things that we just, you know, we fixed it.
Okay,
So
good. I just wanted to make sure that's fixing it. Yes, that's great. So I just wanted to make sure, because I didn't know, I knew if we stayed with the trust, that was part of the plan, was to cover psychotherapy subject to copay. And then now with us choosing or proposing
Right, and
This
again,
means it's within there?
Yes.
right, and because of our prior because of the previous consultant, Dave Stewart, writing it that way, it wasn't in there the right way, but, the NABT hasn't had a consultant that did it the right way. But it was, in the rating structure that we're gonna go over, cover psychotherapy subject to copay, it was 4 cents per employee per month, and, you know, overall 11 cents per employee per month, and that was recommended that be it.
That's an upcoming slide.
Yes.
On the NAEBT is outpatient counseling is $30 copay and outpatient specialty counseling is $50 copay.
Thank you.
And I suspect specialty would be a psychiatrist, but I can verify that.
So licensed clinical social worker would probably be more like a, you know,
Yeah,
family
PCP.
practice internal medicine, that's not a specialist. If you go to Dr. Otasi, and he's a psychiatrist, then that would be like, but he's not, so don't go to him. He's having a heart attack. You get my gist. Sorry, you were there, I had to pick on you. But, yeah, so I think we fixed that. So, I guess,
I make a motion to close discussion and not add an EAP to our existing trust, subject to the discussions of the board next week on NAEBT.
Dr. Otasi?
Yes.
Amy Barney?
Yes.
Al Christensen?
Yes?
Marcia Cox?
yes.
Julie Sissie?
Yes.
Item 4.7, discussion and possible action regarding 2020-2021 benefits and rates. Do you have a motion to approve?
Motion to discuss?
Second.
Dr. Otasi?
Yes.
Amy Barney?
Yes.
Al Christensen?
Yes.
Marcia Cox?
Yes.
Julie Sissie?
Now can you go open the budget?
Yes.
She's gonna
Throw the hat on.
Well, sorry.
Hurry, hurry, hurry. No,
I know.
Get what it's from.
Yeah, I need her to do 10 jobs at once.
While you're bringing that up, I do want to thank ECA and all of everybody for this. I don't know if everybody knows how hard it is to put this together. I do, because I used to have to do it, and that's why I don't do it anymore. But it's a tremendous amount of work, and we appreciate you very much for doing that and having it all, especially since I know how many emails you got from me changing things all the time. It's like, so I could just imagine when you saw my name pop up, I was like, really? Did you change something again? But everything is up to date and wonderful, and we appreciate all of that extra hard work.
Okay, so the rates that we have on the screen right now are reflective of those changes that we talked about yesterday. I have to grab my book, I'm sorry. I do have some answers that you asked of Gilsbar yesterday regarding max out-of-pockets and newborns. No, we're in this again. Newborns. Seriously? That's going in the garbage. So let me just pull up.
So this is when we changed all the copays and deductibles?
Correct.
and whatnot?
So I was just trying to find my notes of what we changed. Over here. Where are they? That's okay. I can wing it. I'm in the wrong spot. Here we go. Okay, apologies. So these rates reflect eliminating the mandatory use of mom for mammograms, removing the limitation on semi-private rooms for hospital facility inpatient stays, there was no cost impact to do that. Covering newborns under their own deductible and coinsurance instead of under mom. In answer to the question about the average cost of those charges. July 18 through June of 19, 16 members had newborn claims, and the average cost during that plan year was $8,135. For the first 6 months of this year, there have been 7 members with newborn charges. Average cost there is $2,880. So I'm not sure why the large disparity, because I just asked for routine as opposed to, you know, if there was an issue. Because if there's an issue, it always goes into the baby's own deductible and co-insurance anyway. So that is a response to that question. Questions on that? This also includes increasing the deductible from $750 for an individual, $1,500 for a family, to $800, $1,600. Increasing the out-of-pocket maximum, which is currently $4,000 for an individual, $8,000 for a family, to $5,000, $10,000 respectively. Increasing the primary care copay from $25 to $30. Covering psychotherapy subject to a regular copay, so taking it out of that weird carve-out we have. Increasing retail 30-day prescription copayments from $10, $35, $65, and that's tier 1, tier 2, tier 3, to $15, $40, and $70 respectively, so it's an increase of $5. Same for the mail or retail 90 copays, increasing from $25, $75, $135 to $30, $80, $140, again a $5 increase there. Increasing the specialty copay, which is currently 20% up to a maximum of $300, increasing that max to $325. Increasing the emergency room copay to $250. That copay is waived when a member is admitted. And then on the high deductible health plan, the changes there are simply to eliminate the mandatory use of mom for mammograms, removing that limitation on the semi-private rooms, and covering newborns again under their own deductible. The one thing again that's not on this list that I mentioned yesterday was we do have the ability to add a broad vaccine network under the pharmacy benefit, which would allow members to obtain routine immunizations from local participating pharmacies instead of having to go to the doctor or the health center, whatever it is. And that could be added at no cost as well.
Could be added at no cost.
Can be added at no cost. So no cost to the employee when they go and get those immunizations, and no cost to the plan for doing that, for adding that. And again, we have our handy dandy spreadsheet up, so if there's any other combinations or things you want to look at, we can certainly, and again, this is all using recommended funding as opposed to minimum funding. The difference again there being the trend rate that the actuary used. 10%, he used a 10% trend rate on recommended versus an 8% trend rate on minimum.
So on the vaccine, the member would be able to go to any
participating pharmacies. So not every pharmacy necessarily participates in that network, but those who do, and there are local, CVS, I'm sure, obviously.
CVS, Walgreens, or what?
Yeah, whatever participating ones, yeah.
Did you ever find out whether, how many people actually hit their max out of
Yes,
pocket?
I'm sorry, I have that right here. In 18-19, 7 members met the out-of-pocket max, which at the time was $6,500. This year, 22 members have met the out-of-pocket, but that's reduced to $4,000. So 22 members have actually met that $4,000 max out-of-pocket.
And Jamie, based on the recommended changes, what would the percentage increase be in premiums 7-1?
So we are looking at, it's on average across the 5 tiers, it's 10.5%.
10.5%.
That's on the gold. On the high deductible, we're looking at basically 15%.
Okay, and then for those who weren't here yesterday or didn't have a chance to look at it, ACA did a very comprehensive look at this and like these different changes, and yesterday afternoon, we sat here and tried a number of adjustments for on a lot of different categories, and the changes we were saying, wow, 10%, can we get it down to 7%? No, we can't. And we tried to just adjust a couple things here and there. And in most cases, it was a 0.5%, 0.3% change in the premium. So, and again, having ECA as our consultant, that's what they do. And again, if anybody wants to look at these pages, you can see all the different recommendations they've given us. But it's just reality that things are increasing in cost, and this is what we're faced with.
Yeah, these numbers started out at nearly 16% across the board, and we priced again, as Mr. Christensen mentioned, a number of different options to look at, trying to get that down. At the same time, I'm always cognizant of the fact that, employees are facing premium increases as well as possibly benefit increases. And so we really tried to, when I was going through and making recommendations, I really did try to look at mitigating that to the extent that we could and still get those premiums to a manageable level for the district.
Sorry.
No,
I'm just talking football.
I was just explaining my rationale.
The Chiefs won, by the way. So,
Yeah.
and so as with the renewal last year, we will be breaking this up. Mr. Murray will get the link so that if you want to separate those out and whatever, we can put that on so we can see that. If you want to spend 27 days or whatever you want to do. I mean, it takes hours and hours and hours to look at that, but there's a lot of information. I think, I don't remember how big it was over 200 pages long. But the actuarial report, I think, was impressive only because it really, and again, that's one of the things that I think was alluded to earlier was when you see the detail on why our claims experience is what it is, and you see the number of high claims, that we have in catastrophe claims, that shows why our rates are the way they are, and all the different variations and options, and why we have to go through all these steps. I think it supports the reasons why we go through all of this, and it's information that I think is valuable to be able to see. So once we go through all of that, we need to maybe send that over to Mr. Murray so he can have that.
We'll post the supporting documents on the website.
Right.
So you
Thank you. And then I don't see any reason why we wouldn't want to add the vaccine on there if there's no cost.
Right.
And then is there a limitation to the, so that's flu, is it just based on the recommendations for preventive?
Yeah, they do,
Yeah.
oftentimes they'll even do the shingles, which you
Shingles.
can't get in a lot of doctor's offices any longer because of the shelf life and so forth. So yeah, it's flu, pneumonia, a lot of the standard kid immunizations, adult immunizations.
Yeah, a lot of staff members were having a hard time getting into doctors to get vaccines if they missed the day that they were on campus, so that would be wonderful.
I think that's a good idea.
I was frankly surprised when I found out we didn't have, it's another one of those weird ones I go, we don't have that? So, easy add.
Easy add, so I think that's a good add. So based on that, and I don't really think that we could dice this thing anymore. I mean, we looked at changing it even or even higher. I don't think that it would make that much difference.
Oh, Jamie, the changes up there are, you've incorporated these, or you still have to incorporate the recommended changes you talked about yesterday?
The numbers that you see up here incorporate those recommended
All those
changes.
recommendations,
Right.
yeah.
Okay,
Yeah.
good.
So, and do we have a copy of that in the, or?
You will.
Okay.
Yeah,
Yeah.
I hadn't finalized it yet because I didn't know if we were gonna play more
I have
with
it.
the numbers.
No, I don't want to play anymore. Do we have any questions about the rates that are up here on the, from the audience at all? No? Any more questions from our board members?
Can't do any motion. No.
There's too many words in it.
You're on a roll now.
Yeah, okay, yeah, the Well,
Well, I had to write it all out.
that's right. Well, I just make a motion that we close discussion and also approve the recommended changes that the ECA has made to us for rates effective July 1st, 2020, subject to if we continue with this trust and don't go to NAEBT.
Second.
It's a tie.
It's fine, pick one of us.
Okay. Dr. Tossi?
Yes.
Amy Barney?
Yes.
Hal Christensen?
Yes.
Marcia Cox?
Yes.
Julie Sessions?
Yes.
Item 4.8, discussion and possible action regarding 2020-2021 existing vendor contract renewals. Do I have a motion?
So moved.
Second.
Dr. Tossi?
Yes.
Amy Barney?
Yes.
Hal Christensen?
Yes.
Marcia Cox?
Yes.
Julie Sessions?
Yes.
Okay, thank you. Last major item on our agenda today. Woo. We have a number of contracts, obviously, that come up for renewal each year. So this process is simply to authorize those renewals and authorize the chairperson to sign the resulting amendments and/or contracts once they've been approved by legal counsel. For July 1, 2020, those include the reinsurance. Reinsurance, as I mentioned yesterday, we can't do until much later, May, June, before that actually finalizes. For that one, we just request that trustees, again, give the chairperson authorization to bind that coverage, and then we bring it back to the trust board for ratification after the fact. We've got Emeritus, who is up for renewal this year, offered a rate pass, so their rate remains at $325 PEPM per employee per month. GDK, which is Mike Bonney, agreed to hold his fee at $325 a month for those compilation reports. Guardian, the life, accidental death and dismemberment, voluntary term life, and voluntary short-term disability carrier agreed to a rate pass for the coming year. United Healthcare, the vision carrier, requested an 8% increase in the vision premium. I can go through those. It goes from $5.18 to $5.59 for employee only. Employee spouse goes from $10.35 to $11.18. Employee plus children is $9.41 to $10.16. And employee family goes from $16.94 to $18.30. Teladoc requested, and this is actually based on the contract, because your utilization of Teladoc is so high, it required a 25-cent per employee per month increase on both the gold and high deductible. So the gold goes from $425 to $450, and the high deductible goes from $3 to $325. All of the other vendors that provide services to the trust are in the midst of multi-year guarantees, and therefore do not need any action.
I think the fact that the Teladoc utilization is high, that's a good thing. Because, and the other thing that I thought was I was glad to hear that we had 58% of the virtual visits were for urgent care with Teladoc, which means that they didn't go to urgent care, they didn't go to emergency room, which is awesome.
Yeah,
And the other thing that was interesting was that I think, I don't remember the percentage, but the vast majority of the average call was Monday through Friday from 8 to 4? It was either 8 to 4, huh? Yeah, 8 to 4, 9 to 4, something like that. Which means that, people didn't, I'm assuming that means that, people didn't have to call, have to get a substitute or whatever, so that's a good thing. One thing too, we also need to remind, send Mr. Bonney a message that he needs to do a accrual.
Yes.
Okay.
Send him a couple.
Again.
Yeah.
Will do.
But, and I think that was,
Just back to the rates for 1 second. One of the things we didn't mention, by the way, is that dental rates are staying the same. So no increase on your dental rates. There's one positive. We take what we can get.
yes, we have an anomaly with our county. Don't you use this as an example for like all of your plans?
Yeah, we do.
99.6% usage.
Prettiest teeth in the county, in the state.
What's the average throughout the state?
85.1.
85,
And ours is 99 or something like that.
99.6.
Go for it, Amy.
I make a motion to close discussion and pending what the school board does if the trust continues, approve existing vendor contracts.
Second.
Dr. Tossing?
Yes.
Amy Barney?
Yes.
Al Christensen?
Yes.
Marcia Cox?
Yes.
Julie Sassine?
Yes.
Okay, and item 4.9, update and announcements.
Nothing from me.
Just want to thank ECA and the vendors that made the trip up here yesterday. And it appears it may have been just a nice day away from work for you yesterday.
Hey, always a good reason to come to Lake.
Always a good reason. Some of the people that hadn't been here were very, even though the weather was a little bit colder yesterday, they all
It was
seemed to.
freezing yesterday.
Oh, it was not. Everybody seemed to enjoy it, so it was nice to have the vendors come up and do face-to-face presentations.
I do have one announcement reminder announcement. We have 2 board members that will be retiring / leaving / abandoning us. No, not really.
Saving lives and selling real estate.
Yeah. There you go, that's a good way of putting it. That their terms expire in June 30th. So if you know of anybody or are interested, something will be coming through the airwaves somehow to you through some source in the next few months. On if you're interested in applying to become an EBT member, just stay tuned because we'll need to. Yes, ma'am.
Clarification, so you do vote on Monday, right?
Monday's
a work session.
Monday's a
work
work
session.
session and then
Okay, so that if we do vote to approve the NAEBT though, then that would not be applicable, is that right?
we would still need to have board members, because our trust would stay in effect for the wind down period, which will be 18 to 24 months.
Okay, that clarifies, thank you.
Yes.
What? Yeah.
Any other announcements or?
Nope.
Our next meeting, EBT meeting is April 16th, but I also encourage everybody to go to that meeting on Monday with the school board and the February 18th regular school board meeting. And with that,
We're adjourned.
all those in favor?
Aye.
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 We are adjourned.